A very good afternoon, distinguished guests, ladies and gentlemen. Welcome to the deep dive session, Resilient Healthcare. I'm Rekha from Temasek Trust. Before we begin, do note that this session is being recorded and will be made available on our website. The first presentation is Economics of Pandemic Preparedness Initiative by Jameel Institute, Imperial College London. Our speakers are Professor Katharina Hogg, Roshni Mehta, Dr. Kelvin Brian Tan, and moderating the Q&A session later will be Uzma Sulaiman. Before we begin, we would like to welcome George Richards, Director at Community Jameel, to say a few words about their support for this initiative.
Thank you very much for the introduction, and thank you to Temasek for their generous hospitality and for inviting the Jameel Institute as a call to action, and us at Community Jameel to be here too. I'm George. I'm the director of Community Jameel. For those of you who don't know us, we're an organization established almost 20 years ago to continue the tradition of philanthropy and community support of the Jameel family from Saudi Arabia. Our mission is to advance science to help communities thrive. And the core thesis of our work is about supporting researchers to develop evidence and data that can inform policymaking as a way of ensuring that government support for tackling key global challenges, poverty, climate change, education, and today, health, can be delivered as efficiently and effectively as possible. We, with Imperial College London, co-founded the Jameel Institute in 2019. And of course, the team has been, as I'm sure colleagues will tell you later, extremely busy over the last few years with the COVID-19 pandemic. But I think, as Katharina said on stage earlier today, one of the lessons of the pandemic has been its multi-dimensional characteristics. The fact that it's not simply enough to look at public health interventions, we have to look much more holistically about the unintended consequences of some actions and the various components of the challenge. It's almost like the waterbed problem. You push down on one side and it inflates at the other end. And that's always been, I think, the problem for the pandemic and the global response. And Pak Budi, the Indonesian Minister of Health, I think put it very well, that the economic impact of the pandemic was severe and something that we need to learn from in order to be better prepared for future pandemics. In tackling such a multidimensional problem as a pandemic or any outbreak of infectious disease, it is essential to look at collaboration. And one of the reasons why we're so excited to be working with the Jameel Institute is that they draw across a number of disciplines within Imperial College London, from economists to epidemiologists and far beyond as well. But also they have an innovative and compelling approach to collaboration outside of their own four walls of the university, with researchers here in Singapore, in Sweden, at multilateral levels with the World Health Organization. And I think that that collaborative, interdisciplinary, multidimensional approach to tackling a challenge of the scale of pandemics is what inspired us at Community Jameel to provide support alongside our friends from the office of Ken Griffin, founder and CEO of Citadel. Really, for us, what it comes down to is the promise of having an impact, but also the inspiration of vision and ambition. And I'm sure, as you'll hear shortly from our colleagues, the vision and ambition of the Jameel Institute's Kenneth C. Griffin Initiative for Economics of Pandemic Preparedness is truly inspiring. Thank you.
Thank you, George. That was an amazing introduction to what I'm going to say now with my colleagues, to just deep dive more into what we talked about this morning. Thanks very much to Temasek Trust and Foundation for supporting us to be here and being able to present our call to action. This morning, we saw that investments into pandemic preparedness are associated with high returns for Singapore. That is great news. On the left side, we can see the socioeconomic costs are much lower in the case that preparedness is good, versus on the right, costs are so much higher if preparedness were bad. That works for Singapore. But the question is it worthwhile to invest in pandemic preparedness for all countries? Is it worth it for all potential pathogens that may cause and inflict the next pandemic on us? Here, we see the pandemic trajectory for one that is very similar to H1N1, also called swine flu, in a very different country in Ethiopia. This is a low-income country and currently not very well prepared for a pandemic. Ethiopia cannot afford lockdowns or border closures like Singapore, and the pandemic is therefore largely unmitigated. Hospital capacity is low and quickly breached, as you can see here during the first pandemic wave. The pandemic costs Ethiopia about 24% of its annual GDP, according to our projections. And this is mostly due to employees being off sick and businesses needing to close. H1N1 is not very severe, and the population of Ethiopia is quite young. That's why the damage of this unmitigated pandemic is not very high. Imagine, though, a hypothetical scenario whereby Ethiopia would be very well prepared for the pandemic because it had invested heavily into pandemic preparedness interventions. Would that have been worthwhile for Ethiopia? Actually, surprisingly, not. Overall, the costs of the pandemic are almost the same in the poor versus the good preparedness case. Clearly, Ethiopia would have been ill-advised to invest into pandemic preparedness. That is the case if H1N1 was the pandemic that they would have been facing. So what we can see is that the business case for pandemic preparedness is not obvious. The benefits depend on many factors, on the severity of the pathogen, on the age distribution of the population, and many other factors. So what we need is solid evidence on the value of investing into pandemic preparedness. The Jameel Institute, as George just mentioned, was launched in 2019 in a partnership between Imperial College London and Community Jameel. The Institute, in partnership with its Singapore partner, the Programme for Research into Epidemic Preparedness and Response, and the National Center for Infectious Diseases, NCID, got together to forge the world's first initiative on the economics of pandemic preparedness. Our joint mission is to develop the sophisticated economic epidemiological models that will help us to project deaths, economic costs, and social costs of hypothetical future pandemics under alternative preparedness scenarios. We have 4 deliverables. The first one is an online dashboard projecting the impact of pandemics, such as the projections you saw for Singapore this morning and Ethiopia just now. We will do this for 150 countries in the world, and it will be a freely accessible resource. We will also develop the science behind it, building on our existing Daedalus model that was developed for the COVID-19 pandemic and that we used to run policy scenarios for policymakers around the world. The research we will conduct will target key areas that we find are weaknesses in our current model. These are integrating behavioral responses that we have found to be so important for disease transmission and also to understand economic shocks. We will also use econometric methods to investigate the economic impacts of the pandemic and then how to integrate them into our model. We will look at infection risk at the workplace and how that feeds back into the community. As a third deliverable, we will work closely with our partners in government, research institutes and international organizations to do in-depth studies in selected countries, and we will be very much led by the problems that our partners have identified. So, for example, Mexico has asked us to investigate how levels of obesity that they are struggling with in their country, how they would impact mortality risk should a future pandemic strike, and what would be the impact of interventions that lower obesity. We will build on our existing partnerships here that we have forged during the COVID-19 pandemic. And largely, we will undertake capacity building with our Singaporean partner to train and embed the next generation of researchers directly into our teams so that they will be able to use these models and also develop them further and make them applicable to specific country contexts. You will hear more about our capacity building ambitions from our Singaporean colleague Kelvin Bryan soon. This is a picture of how the online dashboard might look like on an iMac. So users can, in a drop-down menu, select the country, the pathogen, and also potential mitigation strategies, and then play through how the pandemic trajectory might look like under alternative assumptions. This is a public good to the world and freely accessible. With our partners, we will conduct in-depth case studies. Here marked on this map are the countries that we have identified for a more in-depth studies. We will now show a video with testimonials from two partners we have worked with during COVID-19, and they will show you how our economic epidemiological model Daedalus that we developed for the COVID-19 pandemic was used to inform the policy response. Please start the video.
Yeah, my name is Tonatiuh Barrientos, and I'm the director of the Center for Population Health at the National Institute of Public Health in Mexico. We have been using the Daedalus model in two ways. The first one is to inform our next pandemic preparedness plan. And the second one is to assess the impact of potential interventions that we could have enacted in Mexico to reduce obesity, and through the reduction of obesity, the impact that we would have seen in hospitalizations and deaths in Mexico. And we're also hoping that this will help us realize the importance of strengthening up the health of the population overall to be better prepared for the next pandemic and to have a population that is more resilient to infectious diseases.
I'm Dr. Chathra Vijayasundara, National Consultant for Knowledge Management and Monitoring at WHO Country Office for Sri Lanka. We teamed up with the Jameel Institute of Imperial College to develop an economic model for Sri Lanka during the third wave of the pandemic in the country. Sri Lanka had imposed stringent restrictions during the first and the second waves, and the government was hesitant to impose further restrictions considering the economic constraints that it would have. So it was important for us to advocate to the government on the importance of imposing restrictions to ensure that the morbidity and the mortality would be controlled in the country. So that is where the economic modeling of the Imperial College supported us, where we projected the COVID-19 trajectory in the country over a 3-month period. The results of the model was presented to the senior officials of the Ministry of Health, the COVID-19 Task Force of Sri Lanka, and of course, to the advisors of His Excellency the President. This was taken up by mainstream media as well. This information, along with other relevant information, meant that the government imposed a 6 weeks lockdown instead of the 10-day lockdown that they were initially planning to curtail the Delta wave in the country. This meant there was a significant number of lives saved, with morbidity and mortality being controlled at a short period.
I want to emphasize that we are not sole responsible for tanking the Sri Lankan economy. So now I want to introduce Kelvin Bryan to explain our plans on capacity building. Kelvin.
So the tools we are trying to build is really an integrated sort of economic and epidemiology assessment models. And I think you see that in areas such as in climate change, where they've actually integrated sort of climate models with economic models, and has also helped to sort of move climate action. And I think we need that in this space. I think a lot of us during the pandemic realized a lot of decisions to be made. We had lockdown decisions, border decisions to be made, who to vaccinate, or when to vaccinate. And I think these are the tools we are trying to, in some ways, democratize, and I think that's why we're trying to put it up on the web. But it also involves developing a group of practitioners with the skill sets to use and further develop this model. So I think part of the proposal is to also be able to host some of them here for meetups, sharing some of these through the appropriate webinars, and as I've said, creating the structures and systems and really looking at a certain set of countries where we would get both the policymakers plus academic institutions all working together. Idea of having a case study is also that allows us to drill down and look at certain specific aspects beyond the basic model that we could drill down to sort of look at. And I think with that, I'll sort of pass on to my colleague Roshni to share a bit more of the timeline and how we propose to go about doing it.
Great, thank you, Kelvin. So as you just mentioned, I'll talk about the project timeline. So as you can see here, this project will last over over a 5-year period. During the COVID-19 pandemic, we convened a very small team to support with these deep dive case studies that you just heard in that short video. And the aspiration is to be able to develop these deep dive case studies for one country per year over the next 5 years. The online dashboard, as previously mentioned, will be an open source tool, and by year 2 we hope to launch a very basic platform that could be used or have the capability of modelling different scenarios for up to 60 countries. Over the next 2 years we will further develop that model and that tool to be able to build the capacity or the capability up to 150 countries. What will be a constant activity over the 5 years will be the development, as Katerina mentioned, of our model, and we'll be recruiting specific stakeholders to support with that further development there. And as you've just heard from my colleague about capacity building, we will start here in Singapore, but the aspiration is to grow across the region as well. So to enable us to provide this vital and necessary support, our ask today is for $8.7 million US. And as you heard earlier, we've already had sort of the fantastic news that we have been successful in securing some funding. To highlight some of the elements of the budget to, I guess, demonstrate how we will achieve some of the outputs that I just mentioned on my previous slide. We will have joint strategic leadership from the team in London, but also the team here in Singapore. We will recruit 2 research fellows to provide specific expertise to further develop the Daedalus model. We will have a researcher based both in the London team, but also at the WHO to support with specific policy work. And lastly, we will have 4 studentships that will be based both here and in Singapore to help develop the next generation of future modelers. Other outputs also include academic papers and journals, supporting the development of policy papers, joint partner visits, and also external comms to promote our work over the 5-year period. Now, our aspiration is to grow this work further, and if we were able to raise further funds today, we would like to be able to do these deep dive case studies in the countries here that are highlighted in yellow. Furthermore, we'd like to build on our capacity building output, and we would organise potential roundtable meetings, both here in Singapore, but across the region as well, to bring together other stakeholders from multiple sectors. We'd also like to create academic courses to go as part of the current educational tools based here for capacity building, and that we would hope then would support the future capacity building element of our program. To summarize, our project will help prevent huge shocks to lives, to jobs, and to the public health sector. And we really hope that, that you've been inspired by what you've heard today. I'll hand over to Isma now for questions from the floor. So over to you, Uzma. Oh, one thing I forgot to mention, you can also access all of the details on this QR code, just flashed up then. Thanks.
So I'm quite short, so sitting on these chairs never really works. I'm going to stand in case I fall. So I'm Uzma, I'm the Associate Director at Community Jameel. Thank you all so much for being here, and thank you so much for presenting the health economics piece. So I've got a few questions that came in online and a few of my own, but I thought I'd start with, I think a lot of people think that, the pandemic's over, and, we should be looking at other areas within the health system. I don't know, Professor Katerina, could you tell us a little bit more about why this is important? And how it would work in different contexts in different countries.
Yes, thanks, Uzma. We know it's not a question of if the next pandemic comes, but when the next pandemic comes. This infectious disease outbreaks have been with humanity since known times. Of course, now with climate change and the massive changes that are occurring to the natural environment, disease outbreaks are more likely to occur, meaning that this could be a problem that we have an increased need to deal with coming from the climate direction. Now, we see as well that, of course, many investments that are required to be better prepared for pandemics are also useful in peace times, if you so want. So investments into laboratory capacity, treatment capacity, hospitals, medical staff, training of medical staff, data, integrated data streams, disease surveillance. These are all things that are also very valuable for other diseases, endemic infectious diseases, but also non-communicable diseases that we are facing.
Thank you. So the question that's the most votes here, could you talk a bit more about the impact you see this model having based on hypotheticals? What if we see a new pandemic that doesn't have the same characteristics as the virus in your model?
Yes.
Who would like, Professor?
I'll come in, yeah. All right. I think one of the things that really characterize the pandemic is that there's a great deal of uncertainty even as you navigate your pandemic. I think we were talking to our Minister for Health, and he was saying it's almost like, to use a Chinese proverb, you're trying to cross the river by feeling the stones, right? In some ways, it's quite reassuring that your minister tells you this, because he's saying, I don't expect you to have a perfect decision or solution that's there. We are going to figure out as we go along, not make it up as we go along, but figure it out. But I think that's the beauty of having a model where people in different countries can put in different parameters and adjust it and see how it might react. And I think that's the importance of it, because if you look at it, I think singularly, different countries have really adopted very different strategies. We can all talk about success a bit later on and evaluation, but I think it really reflects policymakers really making the most of what they know. And I would like to add one more thing, is that I think such models also do allow for that kind of exchange of information across countries that might sometimes be very difficult because of whether it's political sensitivities or the fact that we just don't have the time to do that. And I think we're really hoping to really also improve the capability of decision making, especially of countries and in making such decisions as we go along. Yeah.
Great. Roshni, Professor, is there anything you'd like to add?
Nothing to add. Thank you.
So will you work directly with treasuries and other key stakeholders in government to present your scenarios? Roshni, would you like to respond?
Sure, and then please do jump in, Katerina. So the model at the moment is we work with the WHO to support with specific, as Katerina mentioned earlier, specific needs for that country. So there will be topical issues that are relevant for different countries. And the way that we've been currently working is through different partnerships, mainly through the WHO. The role of the team and of this model is to provide different scenarios for then policymakers to make their own choices about how best to roll out different policy choices for their populations. Katerina, anything else to add?
Yeah, so we saw that it was actually quite challenging to get treasuries and public health agencies together in one room to respond to COVID-19. And in some countries that has worked really well, in others not so well. What we are trying to do with our work is to express the lost lives in monetary terms with approaches that have been developed in environmental economics and other areas, because if a dollar sign is in front of it, then treasuries do understand.
Could you talk a little bit more about the capacity building built into this initiative as well, and who are the kind of people that you'll be working with to develop the capacity building?
Yeah, so I think specifically, just to go back to the previous question, I think if you look at countries that I think have done it best is countries where they've been able to bring together the policymakers, the scientists, and to a certain degree also the clinicians, which are very critical because they're on the ground to do that. And it's not easy to bring everyone together. In part also, there's also a lot of knowledge gaps that we all have to fill to do that. So I think sometimes having that model allows us to sit down to share that aspects of it. I've seen it in climate change, where actually you do get the climate scientists to be able to exchange with, say, people who are more economics trained or more concerned about the bottom line. I think these models allow, in some ways, a neutral ground and platform for us to share that. So I think part of that capability building is we definitely, to build such capability, you would need people in your government circles, in your policymakers, or at least playing an advisory role in the policymakers. I think it's important that we involve them in this network. Ideally, you do also need, I would say, your scientists as well as your clinicians in these countries to be working with them. And we're hoping really to use a model like this to get people to work together. Yeah.
Is there anything else you'd like to add, Roshni, Professor Hauk?
No, perfect.
I'm going to ask some questions on data. At Community Jamil, we love data. Oh, George, would you like to ask a question? Yeah.
Thank you, and we do love data. Yeah. No, but just one question. How do you think it might be possible to control for a selection bias of countries that would be willing to engage in a deep dive with this initiative? Might they already be the kinds of countries that are likely to have an evidence, data-informed pandemic response anyway? And how is it possible maybe to reach out to countries that don't tend to have that kind of a response and ensure that in future they actually have stronger resilience to pandemic risk through engaging in a more evidence-based approach? Thank you.
Yeah, so what we actually find is that, of course, the ability and capacity of governments to work with us is dependent on the political situation and can change quickly sometimes, unfortunately. So what we find is that in these situations where it's really difficult to engage on a higher level, an approach is to just talk to the younger generation and involve them directly into our work. And now with online working, that's actually often quite fruitful. And make them part of our team, make them part of our regular team calls. That's supplemented with online training courses that Imperial College has, and that we also provide dedicated in specific countries. For example, this week we are in Zambia to provide training. Is I think a great approach to build up the next generation.
Yeah, I think the other platform that we'll also be trying to work with is organizations such like WHO, especially also in some ways the regional offices, say Wipro as well as Zero in this region, in part because actually a lot of their work is really to help level up some of the countries that where capabilities are not as well developed. And I think it's a very important role. And I think when we do collaborate, especially for the Singapore partners, I think that regional role is a critical one. It's challenging, and I think in this Southeast Asia region, it's very diverse. So I think that's something that we are hoping that we could sort of bring together, but it's definitely top of our mind. Yeah.
Thank you. Are there any other questions from the audience? There is a QR code, so you can ask them. But also, how will this project support gaps identified in data collection?
Yes, so I mean, the data we use on the economic side are collected by countries as part of their national accounts. They are, of course, associated with many limitations. So that's why with countries where data are so limited that we can only provide really rudimentary scenario analysis, we hope to be able, and if we attract further funding, we would be able to extend this work to many countries to just look at very specific issues that are of concern to them, and then actually potentially go out and collect these data, or at least collate them with our partners in order to give more targeted recommendations and more targeted scenario analyses.
I was just going to say one thing that's really, really encouraging is, during the pandemic, you have several important websites which have provided aggregated data across countries, like the Johns Hopkins website and Our World in Data. That's on the disease side. You do have similar databases on the economic front, but I think we haven't seen people trying to bring the two together, and I think that's what we will try to do. And I think there's actually sufficient open source data out there that we can work on. But I think when we do want to go into some of the drill downs, I think that's where additional data will come in. And we hope that with some of the insights they can get with the data is just out there, people will be a bit more open to say, hey, look, I'm quite interested in adding more data to it. And we'll also be encouraging them to share some of that to a much broader platform and community.
Perfect. I think we're just at time. That's a great way to end the session. Thank you so much.
Thank you.
Thank you. Thanks, everyone.
Thank you, Professor Hawke, Dr. Tan, Roshni, and Uzma. Next is the team from SingHealth Duke NUS Maternal and Child Health Research Institute, who will be sharing about genomics for kids in ASEAN. So let's welcome Associate Professor Ng Kee Chong, Dr. Saumya Jamwa, Associate Professor Tan Yi Shen, and Professor Jerry Chan.
So again, we'd like to thank Temasek for supporting the SingHealth Duke NUS Maternal and Child Health Research Institute, in particular our project on the genomics for kids in ASEAN. So I will first get Professor Jerry Chan, Director of MCHRI, to share with us about MCHRI, and then he'll be followed by Professor Tan Yi Shen, Head of Genetics, and also co-lead for the genomics platform in MCHRI, to deep dive into the genomics for kids in ASEAN. And then I'll be co-moderated with me, and Saumya will be moderating with the questions on the floor afterwards. Thank you very much.
Hello. Thank you very much for the introduction. I'm Jerry. I'm actually an obstetrician and gynecologist by training. As the director of the MCHRI, I was just going to share with you a little bit about what we're trying to do in Singapore and hopefully in the region as well in terms of our strategy. So, okay, just moving on. Essentially, families need a best start to a healthier future, and MCHRI was actually launched just last year by our minister, and we are trying to pioneer innovation and digital strategies to address the biggest problems we have in Singapore at least, and that is no longer maternal deaths or infant mortality. It's shift off to a different kind of target. We're talking about metabolic problems, lots of overweight, obesity in our population right now, and also a mental health problem. Along the way, we have a very low total fertility rate, so we're also trying to address reproductive health and also enhancing neurocognitive development in our children. And of course, we will continue to develop cures and treatments for cancer and other illnesses. So in a national level, in a snapshot, we could look at the top line over there. The final point we're trying to get to is a healthier population in line with our national strategy. And this always starts with a healthier individual, healthier couple, and therefore a healthier family and population. And we use a life course approach to address this by looking at what happens even before conception, through pregnancy, all the way down to postpartum, early life, and adolescence. So we do this in order to achieve different outcomes. A lot of the outcomes here are based on better metabolic and mental health, and for the child, obviously, good development and also habit formation. So we aim to be Asia Center of Excellence for maternal and child health, and we work with all local consortiums, health institutions, academic institutions like our universities, the government ministries, and also quite a lot of philanthropy, including Temasek itself. So in a nutshell, this is what our area of operation or influence is going to be like. We look after women in preconception. We bring them through a healthy preconception life so they can have a healthy pregnancy, leading to a healthier postpartum period, where we tie the health and health plan of the mother and child together to impact on metabolic health, fertility. Also, we mentioned before, neurocognitive, social, emotional development, oral visual health, and looking at also in childhood infectious diseases. We have developed a suite of capabilities, all the omics here, and also health service research, implementation science, and data integration. And later on, my colleague, Professor Tan, will talk a bit about what we're going to do about genomics. Finally, just to share what we're doing already right now, we are establishing a plan, a care plan that actually strengthens health across the entire lifespan. And we are intervening in the first 1,000 days of life in preconception, pregnancy, and postnatal dietetic care. And what we're really trying to do is convert metabolically and mentally unhealthy lifestyles into that of a healthier lifestyle. And this would impact on positive maternal-child health outcomes using scalable strategies, capitalizing on electronic health, and to impact on the maximum gains of maternal-child health. Lastly, global health. We are looking at basically UN Sustainable Goals, SDGs, specifically 3.1, 3.2, and obviously 4.1 for education. We hope to partner with philanthropic partnerships as collaboration increase our sample size and enlarge our reach. Okay, after this, I think we're going to play a video on the genomics part. And then Prof. Tan will take over.
At 3 months old, my parents brought me to our family doctor, and he realized that I was really floppy. So the doctor referred me to a specialist to check. It was a pediatric neurologist, and I did many blood tests. I cried about it each time until I was referred to a genetics doctor, Dr. Angeline. It was only until 8 years old that I had my diagnosis. I feel very relieved and happy to not go through this painful process so often.
When Jaden was born, we realized that his developmental milestone was not on par with his elder siblings. That got us a bit worried, so we were seeing a few doctors to have a second opinion for his condition. He was only able to sit on tripod with back slightly bent. He was not walking. We were quite lost.
My husband and I, we were both confused. We didn't quite know how to support her, especially in the first few months of her life. We didn't know what was dystonia, so we went to do our own reading. Apart from the medications, we also worked with the professionals from the KKH therapy. Genetics testing has helped me with ways to support and understand what might happen, have happened and are happening in my journey with Dania.
Tôi nghĩ rằng việc khám sàng lọc gen trước khi sinh rất cần thiết và quan trọng, sẽ giúp cho loại trừ bớt những cái nguy cơ mà các trẻ bị mắc bệnh di truyền, bị vật cẩm sinh, giúp giảm đi gánh nặng ngành y tế và làm cho gia đình hạnh phúc và xã hội sẽ bớt đi gánh nặng. Cảm ơn ạ.
After I got my diagnosis, my parents felt relieved and the doctors can give a better health development care for me.
So Bridges actually help our family to save the cost in the process of searching for the diagnostic result. Before that, our life will focus on actually finding the diagnostic cause of his condition.
It will help us to find the strength to focus our attention and effort on supporting what we know at this present moment. It's a journey, so as caregivers, I think we need to feel supported in order to better care and better support our children in their journey as well.
So being involved in Bridges, actually, we get the update from the doctors involved, and we are known about the progress of the result of our test. At which stage, what do we need to do, or we do not have to worry.
I think this program should be made available to more families because it can help the parents to get a better perspective of this rare disease and know what to do next.
Hello? Yeah. I feel like I don't have to speak after that video. And I think we're very grateful to our patients for sharing their stories, and they came forward very quickly to want to lend a voice to support this program, Genomics for Kids in ASEAN. We have 4 different patients with 4 different conditions, but a very similar journey that they walked through in receiving a diagnosis. And in this journey is what we often call a diagnostic odyssey, and it's common in rare disease patients. It's an odyssey because it's a very long journey. It's a journey of adventure and sometimes arduous. And in ASEAN, 1 in 20 babies born every year will take this journey. And more than 10 million individuals in ASEAN will also take this same journey, which is the diagnostic odyssey. I think in this day and age, when we see a doctor with a cough or a fever, we expect a diagnosis fairly quickly. We expect treatment, all within a day or 2, if the doctor is slow. But if you have a more complicated condition, for example, cancer or heart disease, you may get 1 or 2 more scans, you may get 1 or 2 more referrals to specialists, but you still get your diagnosis within a reasonable amount of time. But it's estimated that patients with rare disease see 8 physicians, an average of 8 physicians. They have 2 to 3 wrong diagnoses and 7.5 years before they receive a diagnosis. And this is not exaggerated numbers. You heard Hannah share earlier that she was only diagnosed at the age of 8 years old. So this is not the journey that we hope to see for our patients, and it's a really difficult journey. What we hope to see and what we've been trying to build in Singapore for patients with rare disease, a journey that should look like that. It should look like a very quick, any other illness that we have faced, that they get noticed early, they get referred early to the genetic specialist, they get appropriate testing early, and they get results early. And all this within a diagnostic cycle that is reasonable in time. And the benefits that we see to this cycle really is an end of a diagnostic journey that the patients have shared earlier on. Tailored care to the patients that's specific to the disease, not just trying to treat their symptoms, and also genetic counseling so that they understand the impact to themselves, to their families, and even to their extended families. And the end of the journey is not just finding an answer, but you actually get a change in diagnostic treatment, in management. You may change medications. There may be things that we can do. In 70% of patients, we actually get changes in diagnostic strategy, meaning that, like Hannah also had shared earlier, she doesn't need to go through any more invasive blood tests or even surgical procedures. Now, of course, all of them do benefit for genetic counseling, where they get more input into their reproductive options. So the diagnostic odyssey that I spoke about is common across the globe, across the world, it is the same. But I think in ASEAN, it is particularly long, and purely for a few reasons. First reason, I think, as Pak Budi very nicely alluded to in his inspiring message this morning, human resource is scarce. So if you look at the number of genetic specialists, the number of genetic counselors that are available in the various parts of ASEAN, this is simply not enough. Data from the US suggests that you need 4 geneticists per 1 million, and you need 14 genetic counselors per 1 million. But in ASEAN, we are not even near those numbers. So it's not just about the human resource, but if you look at this journey that we're trying to achieve for the patients with rare disease, at every point there are obstacles and there are challenges to overcome. At the very first point, do they even know who to look for? Does anyone suspect a rare disease? If they do, are there clinics, are there doctors that they can send the patient to that can help to evaluate the patient? Are there laboratories that can do the testing? And in ASEAN, there's a lack of clinical genomic laboratories that can do the testing. And even if it's available, the cost is prohibitive. So at the end, even if they get a test report, who is able to counsel them? Are there genetic counselors that can tell these patients and make that information relevant to the families? So there are challenges really all through the cycle of diagnosis. And really with this program, we aim to tackle every single challenge that is there over time, but we do aim to do that. Our desired outcomes is really to improve access to genomic services for every patient with a rare disease in ASEAN, to work with the local physicians and communities to improve regional capability and capacity, and also to come together to build an ASEAN-specific genomic database. I'll just go into it a bit more detail. So improve access to genomic services. Very simply put, any patient with a suspected rare disease, regardless of where they stay, how accessible they have to medical care, their resources, they should have access to genomic services. And with that, we hope to provide genetic testing for 740 families across 3 years for the patients in ASEAN. And it's not just testing. We hope to make the reports relevant to them, explained clinically, and also provide adequate genetic counseling for these patients so they have the full suite of genomic care and not just the tests. We want to come alongside our regional partners. We can't do it alone. We are not bringing everybody here. What we want to do is to build capacity and capability in the region to work alongside those that are in the local setting, the physicians, the nurses, the healthcare professionals, and to really enable them to take care of the patients in their country. In Singapore, over the past 4 to 5 years, we have been doing workshops and educational programs targeted at many different levels of healthcare professionals, right from nurses, frontline staff, to specialists in different cardiologists, neurologists, and really to equip all these individuals at different levels with genomic literacy. We also want to build an ASEAN-specific genomic database. This is important because, for example, in the US or in Europe, I think we've all heard of cystic fibrosis. Programs are built around it, resources, are put into it, screening programs are built because cystic fibrosis is a very common genetic problem in the US or in Europe. But we hardly see cystic fibrosis in our country. But what we have seen is actually a not so well-known condition known as citrine deficiency. So citrine deficiency actually presents as jaundice. So a lot of babies in the first couple of days, we all know that the babies get a bit yellow. But in citrine deficiency, this jaundice doesn't go away. It can be prolonged, and it can actually also lead to liver failure. And the treatment is actually simple. It's not complicated, it's not expensive. It's simply removing lactose from the milk. So because we know this is an important rare disease in our community, this has been built into clinical guidelines so that the frontline staff, frontline doctors, baby doctors, when they examine the baby and see a jaundice that is not going away, they know to look for citrulline deficiency, they know what to do. And also we are developing newborn screen to start to identify patients before they even develop symptoms. So I think once we know the epidemiology of genetic disease in ASEAN, we're better able to tailor our medical practices towards it. We're better able to also move our healthcare resources. Rather than tackling something like cystic fibrosis, we will tackle citrulline deficiency. So we hope to do this over 3 years. This is our timeline. Sequencing really forms the base of what we are doing, and we aim to sequence 740 families, and that is 2 adults and 1 child. So that's actually a total of almost 2,000 odd individuals across 3 years. But apart from sequencing, very importantly, we are going to build foundations and bring in genomic education, bring in training for the different levels of staff, the doctors, the nurses, the genetic counselors in the region, beginning with 1 ASEAN country and expanding to 2 others in the following years. We'll continue to build our database to enhance that database such that even the physicians from overseas can access this database. And you know, underlying all this is the fact that we may discover new genes, new syndromes. In Singapore, we have done sequencing for about 600 families over the years, and we have discovered 6 new genetic syndromes. Well, the money, we all do need money, and at the end of the day, this is our budget breakdown, with a bulk of it going to sequencing, and also the building programs in genetic counseling, and of course, training of the healthcare staff, and also the genomic database. And 4.2 million is what we expect we will need. Very, very grateful that Temasek Foundation has actually come alongside us to start the contribution at 2 million. So I think we started with the voices of the patient. We should end with the voices of the patient. This is a letter that was written by the lady in the video. It's the second lady. And she wrote this letter to us after her son was diagnosed with a rare disorder, and we gave her the diagnosis. It articulates very well the journey that they all walk through. That's frustrating. They don't know what's wrong. But it also shows that with an answer, it's the end of a diagnostic journey, but it's really the beginning of hope for them to find answers, the beginning of them being able to find others with the same condition, and that means a lot to the families. And at the end of the day, they actually all come together to support us building these programs in Singapore and in ASEAN, because they all know the journey that they have walked through. So we hope that you'll partner with us. I mean, genomics is a fancy thing and a big thing, but we really want to harness these advances in genomics really just to simply help the child and their family. Thank you very much.
Thank you very much, Jerry and Ishan. So now we will have the Q&A and questions. Samia, you want to? Yeah. So maybe we start with any questions from anybody in the room, on the floor? Yeah, you sit.
We're happy to take live questions as well.
Any
I think since it's a smaller. If not, if we can always go. Okay.
You start first, Samia.
Okay. So the first question. Oh, okay. Nobody wants to sit.
Well,
I'm too short. I tried sitting on it yesterday. I thought I'd fall off.
And then Pure Team showed us.
So the first question to Ishan is genetic sequencing all that is needed for patients with rare diseases?
Definitely not. I mean, it's a very important component, and that's why our program not only focuses on testing, but it's really the end-to-end, right? Picking the right patients, clinically evaluating them, giving them the results in a way that they understand that is relevant to their medical condition, and also genetic counseling. So it's easy to get a report. I mean, nowadays people kind of swab themselves, send it somewhere, and they get some sort of report. But understanding that report and making it relevant to them, I think, is also a key component of genetics. Yeah.
Anything else to add, Jerry? Or? Yeah, so the important thing is the end-to-end thing. It's not just the test itself, but it's also the follow-up action. And we want to work closely with the, our partners in the region to actually then follow up the patient carefully. Okay, next question is this term rare diseases. Okay, why should countries in ASEAN focus on rare diseases since they are rare?
I'll let Samia speak.
So what is a rare disease and why is it so rare and why should we focus on rare things?
Yeah, so I think the context is that 1 in 20 babies are born with a rare disease, but there are 7,700 of them. So individually, these rare diseases are rare. You don't have a lot of people. So most of us may not have met someone with rare disease or have heard of rare disease, but cumulatively, they add to a huge number. And that number in ASEAN is more than 10 million. So there are 10 million children going around who have not been diagnosed because people don't think about it. And this is a challenge because their management is simply focused on what they present with, not giving a care that they need. So a patient with rare disease, just like any other patient, would have a cough and a cold. But because of the rare disease, they may not be able to recover as well. They end up in the ICU. Understanding that the patient has a rare disease, you can anticipate, push forward some of the management strategies to help the patient recover faster. So.
Yeah, and certainly, I mean, even when you look at, I think Lancet recently published data on infant mortality as well as mortality for those less than 5. And congenital malformations, birth defects, and part of genetic diseases are still a significant cause in the first 5 causes. So yes, there are important pandemic and many other health issues, but rare diseases are important too.
And if I just add the financial cost to it, since we are talking about, in the US in 2013, it was estimated it costs $22.9 billion to manage patients with rare diseases. And that number is just going to go up over the years. So it is a huge cost to the healthcare system. And often it's an unknown number because you don't know that it's a rare disease.
So maybe just chime in. Every life is precious. So especially a child's life. And this rare disease, when Ishan was sharing about Citrine, this is a group of undifferentiated diseases, right? So we don't know what is the subset, what different categories of conditions. Like the Citrine that Ishan shared is actually a common thing, actually, relatively, in this whole plethora of rare diseases. So when we say rare diseases, it's just a term to indicate that this is a basket of undifferentiated diseases that we have not diagnosed yet. It does not mean it is rare in that sense. And rarity is in terms of numbers, but in terms of the qualitative impact of the disease on the families and society is also, can be very significant. So it's not just, rare disease and therefore it's rare and we, invest in it less.
Yeah, if I may just add, I mean, basically, if you have a genetic diagnosis, you can then start to think about treatment modalities a lot more cogently. For example, there's a growing body evidence of gene therapy, and we've done it for spinal muscular atrophy. And things like gene editing is going to come on board very soon. That's going to impact on it. So that, once again, it starts all the way from genetic diagnosis.
So the next question, Jerry. The maternal child health roadmap by KK Hospital is impressive. Beyond genomics, will you take the plan to the region?
I think if we think about the ultimate outcome of MCHRI, it is to actually create the best start for everyone. Aside from specific rare diseases, which is not so rare collectively, we address the biggest problems, the biggest elephant in the room, right? So in Singapore, and actually quite surprisingly, I was told by my regional colleagues that obesity is actually a big problem. Even in Philippines, Malaysia especially, Indonesia, Cambodia, everyone is just getting McDonald's, I suppose. So I think there's a lot to be said about fetal programming, from the background of an obstetrician. A lot of what your mother eats or do during pregnancy or even before pregnancy as the egg matures or the sperm matures over 3 months and 6 weeks respectively, what you do impacts on how your body responds to its environment. So in many ways, we're a bit like turtles or crocodiles. The temperature goes up, you get a male phenotype and things like that. We see the same things happening to fat cells. If you grow in a diabetic environment when you're born, that happens. So one of our greatest, envisioning done was to create the best metabolic start, and that comes hand in hand with mental health starts as well. Of course, different countries regionally will have different priority areas, but certainly educating, forming good habits and all these things along the way will form a very important part of our mission.
Okay, question for Yi-Shen and Samia. How are you going to select the 740 families? And what are the partners that we have, currently in our ecosystem?
I'll start with the partners. So I think over the years, we have built up collaborations across Southeast Asia. In ASEAN, we have collaborators in Indonesia, Vietnam, Philippines, Malaysia, and many other countries. And really, I think everyone, it's a very close-knit community because we're in a space that is rare in that sense. And I think we all would want to come together to collaborate because we see the power of collaboration in this region. So I think that's one area that we're working on. Yep.
How are you going to select the 740 families?
So again, working with the partners, we will identify individuals or patients who have a subset of symptoms which point to a rare disease. So as I mentioned earlier, there's more than 7,000 rare diseases, but as Ki Chong said, they all converge and they present with similar symptoms. So these symptoms will include the child can't walk, can't talk, may have some intellectual disability, gets recurrent infections of the lung. And so the idea is to identify this group of patients. And again, working with the collaborators and giving them the knowledge that these are the patients that need to be sent for testing. And as part of the capacity building process. So the patients will include patients with developmental problems, problems that affect multiple organs. So if a child has a problem with the heart, the kidneys, the lungs, those are the type of patients we would want to include in this cohort. The second overarching criteria is that this is to help patients from the underprivileged and under-resourced families. And so that is again part of the program that we're trying to use these funds to help those families get to a genetic diagnosis faster.
I think time is run out, but maybe last question. What happens after diagnosis? Is it costly to treat? And how much will treatment be?
I think that would vary. So like I gave the example of citrulline deficiency. I know sometimes we think about treatment as gene therapy, and that's really the expensive end of the spectrum. But it can be as simple as citrulline deficiency as giving lactose-free milk. And that is the treatment that is needed. In a group of disorders that are rare, we call inborn errors of metabolism. It involves adjusting diets, giving certain supplements. So it really varies in terms of what the disease is.
I think the important thing also for the families, they will have the end of the diagnostic odyssey. They will know what condition the child has and actually just move forward. I think that's very, very important also for families who are still searching for a diagnosis.
Yes.
Just nice. Okay, any other questions? Any questions from the floor? Anybody in the room? Okay, thank you very much. Thank you.
Thank you.
Thank you very much.